Good morning, everyone, and welcome to the Mailman Center Grand Rounds. We'll get started in a minute. We'll just give folks a chance to log in here. As folks are checking in, I'll remind everyone to mute yourselves. We decided to make this a regular Zoom meeting so we could have some interaction and discussion. But that requires all of us to be vigilant about our mute button. So please do put yourself on mute.
Jeff, one other suggestion that came in yesterday because of broadband issues is during these presentations for everyone to also turn off their live video. That helps to cut back on some of the broadband use.
Great. Thanks for the suggestion, Danny. All right, well, it's 8:02, so I'd like to get started. My name is Jeff Brosco. I'm an Associate Director of the Mailman Center for Child Development, and this is our monthly Grand Rounds, and it's also the Pediatric Staff Conference, so we have the Department of Pediatrics, our community partners, and Mailman Center all together this morning. And I'd like to quickly introduce Monica Dowling, who's one of our psychologists here at the Mailman Center, who's done wonderful work with testing and helping figure out what's going on with kids, and she's going to introduce our special guest speaker, Dr. Dowling.
Good morning. It is my pleasure and it's my privilege to introduce Dr. Stainbrook. She is the Associate Director of the Treatment and Research Institute for Autism Spectrum Disorders at Vanderbilt University Medical Center. She and her colleagues have worked tirelessly to overcome barriers to serving families, educators, and service providers in rural and under-resourced communities, which is one of the reasons why it makes her relevant for us. She is also the Director of Early Learning and oversees the development and application of telemedicine service models to provide assessment and intervention, as well as training to providers. So her experiencing providing telehealth to under-resourced communities really is a model that is particularly relevant in Miami today as we deal with COVID, and many of our patients that we serve, we can't really reach them at Mailman. So I am most eager to learn about her experiences with Tele-Delivery. So please welcome Dr. Stainbrook.
Thank you so much, Dr. Dowling, and good morning to everybody. Let me try to share my screen with you guys. Does that look okay, Dr. Dowling?
Yes, sorry, I muted myself already. I can see you fine, so I'm going to assume everyone else can.
Great, wonderful. Well, good morning, and thank you so much for having me this morning. I am really excited to share with you about our experiences with the Tele-Delivery of early intervention services specifically for young children with autism spectrum disorder. I'll start by giving you just a little bit of information about Triad for those of you that might not be super familiar. Triad is part of the Vanderbilt Kennedy Center, and our center, much like yours, houses a variety of programs aimed at supporting individuals with disabilities, their families, and their service providers. At Triad specifically, as Dr. Dowling shared, we're really focused on how to increase access to assessment and treatment options for young children, but also how to build the capacity of service providers across our state to work with these families and children. So that being everything from early intervention providers to educators to physicians. And we also engage a good bit with our community and building community partners, trying to establish partnerships with folks like the Nashville Zoo and the opera and the ballet to create really inclusive events so our families are more comfortable going out into the community and experiencing those opportunities. I'll be happy to talk to you when we get to the Q&A part about any additional things that you'd be interested in related to Triad. Our telemedicine work really flows across all of our lines of service. So whether that be with our assessment, our treatment, which I'm going to talk a little bit about today, our provider training and coaching, our work with educators, and even our community outreach work, we see themes of telehealth and telemedicine, especially since COVID, but even prior to COVID. So the work that I'll be discussing with you today is very much a product of our close relationship with the Tennessee Department of Education, the Tennessee Department of Intellectual and Developmental Disabilities, and most specifically our Tennessee Early Intervention System. These partnerships have helped facilitate the funding for a lot of the work that I'll share with you today, but it's also been through these partnerships that we've really been able to meet the specific needs of our communities. And we're also grateful that they have put a lot of trust in us. And when we bring a crazy and what we think is innovative idea to them, they've been very supportive of that work. So here's what I hope to share with you today. Generally, our utilization of telemedicine as a service delivery method for early intervention, some of the strategies and resources that we've developed to facilitate the success of that model, some of the benefits of telemedicine for supporting not only families, but also service providers. And then I'll talk a little bit about our methods for collecting outcome data and evaluating our program's impact. I do want to leave a good bit of time for questions and conversation at the end. So if I go through anything too quickly, please do bring that to my attention at the end and I'll be happy to circle back. So as I've already mentioned, we do have a lengthy partnership with our state's Department of Ed and DIDD programs, and that has really been focused over the years on supporting young children with ASD, their families, and their service providers. But for a long time, those support opportunities were really limited in accessibility to those living closest to our medical center or in other really highly resourced communities in Tennessee. So it's really been within the past 3 to 4 years that we've shifted our efforts to reaching more rural and under-resourced communities. Across much of our programming, we've accomplished this through starting with little itty-bitty pilot programs that we've been able to demonstrate success and then replicate and extend that across other counties or communities or regions in our state. Before we dive into the details of our current model, I think it's really helpful to tell the story of where we have been as it relates to early intervention and our relationship with our Part C system specifically. So this partnership was initiated in 2014. And at that time, like many centers, we were seeing a ton of kids for early identification for autism. And our providers were getting pretty frustrated with continuing to write in their reports, seek ABA services, find a behavior analyst. These are services that would be really helpful for you. And our family struggling to find that due to barriers related to insurance coverage, just general access, there being a shortage of behavior analysts in certain districts of our state. And so we partnered with our Part C system to develop a model that was really focused on getting support to caregivers as quickly as possible following that identification or evaluation for autism. So regardless of the outcome of that evaluation, we wanted to get to those families and provide at least a brief service to help them understand what the outcome of that evaluation means and get them started with some just simple strategies they can use at home to enhance the quality of their own lives and also the development of their child. Pretty quickly into that, we realized that there weren't quite enough of us to serve the number of families that were coming through our doors. So we're a team of behavior analysts, speech language pathologists, and early childhood educators, and we're a team of about 12. And so serving all the kids, even in the Middle Tennessee region, and then later in our the western part of our state, was a tricky thing to do. So we continued to have these conversations with Part C and decided that one of the ways we could have a greater impact would be through partnering with these Part C providers who are already out there with the families every week until the child turns 3. So in Tennessee, I'm sure much like Florida, families that have an IFSP generally have a developmental therapist that works with them once a week, maybe twice a month. And that therapist is going to be able to address general concerns related to child development and family quality of life. Their backgrounds, however, in ASD, challenging behavior, behavior analysis really vary. And so that's where we felt like if we can connect with these providers, co-treat during our visits, and then continue to provide some support to them when our services are done, our service, our information that we're sharing with families is going to have a much greater impact, not only for that family, but also for all the other families that that provider is working with. In 2016, we, at this point, had spent enough time with our providers to know where some of the gaps were and started to develop some professional development opportunities for these providers. But more interestingly, for this talk specifically, we started to think about, okay, we're a small group still. We're incorporating the support from these service providers, but we're still driving 1-2+ hours one way to support the needs of these families. And how many more families could we support if we were able to meet them closer to somewhere a little closer to their home, still close to their home, but not requiring us to drive so much. So we began to set up some satellite clinics where caregivers and their service provider could come. Generally, this would be still within a 30-minute drive of their home, hopefully less, and connect to us at Vanderbilt to provide some teleconsultation around the work that we had been doing in the home. So we might treat that family for a few sessions in-home collaboration with their provider, and then fade that support to a teleconsultation model. In 2017, we continued to think about that capacity building piece and also have realized that we were doing a lot of the same things with families. We're addressing a lot of the same needs. So not surprisingly, our caregivers are generally concerned about challenging behavior, communication, sleep, social play skills, and every once in a while we'll have some eager families that really want to jump on board with toilet training. And so we developed some curriculum modules that were meant to be accessible to caregivers, also accessible to providers, and something that could be covered over 6 to 8 visits with a family. Those curriculum modules are written broadly enough that they support families at a variety of levels and children at a variety of levels, but have guides within that help really individualize that work. This was also the point where some of you may be familiar with our telediagnostic model for consultation. So not only did we want to provide services to families in these rural and under-resourced regions through the hope of telemedicine, but also beginning to think about how can we potentially identify autism from a distance. So we set up another clinic in the western part of our state where families could come, and I'll detail this model in a bit more in the next slide, where families could come and access that evaluation for autism through telemedicine modality. And that brings us to where we are today, which is really on continuing to think about, and in response to COVID, that's been fast-tracked a little bit, how we can provide services potentially exclusively through telemedicine for families that really are distant from specialty providers, and how to continue to build the expertise of those service providers that are already in these communities that might not be behavior analysts or speech language pathologists, but have the baseline skills to continue to grow and become local experts. All right, our evaluation for ASD is the entry point for families into our intervention service line. Again, since my focus is on the intervention piece today, I'm going to try not to talk too much about the diagnostic side, but I did want to let you know that there are a couple of papers out there if that is something of interest to you. We've published 2 just kind of detailing the model itself, the accuracy of that model, and the acceptability in the communities where we've worked. And then we have 2 additional papers that are currently in press that have taken that model and shifted it even farther to a parent-mediated variation. So let me walk you through the telediagnostic consultation briefly, and then we'll shift entirely to the intervention model. So like I said, the goal of the telediagnostic is to meet families closer to their home. So a family demonstrating concerns for ASD doesn't need to travel all the way to the middle of our state. That star there is where Vanderbilt would be. So we might have a family that lives all the way in the southwestern region of the state. It's about 200 miles from Vanderbilt. And rather than have to travel that distance, maybe they can come to one of our satellite clinics that's still not super close, but about, 2 hours closer than they would have otherwise had to travel. There, they would meet with one of our triad consultants who actually lives in that region. And that consultant would screen to determine the appropriateness of this specific model, because this is a briefer evaluation for this family. And if it's an appropriate fit, schedule that. And at the time of the appointment, the family would come to that clinic closer to home and connect to one of our Vanderbilt psychologists. During the appointment, our triad consultant is administering the STAT, the screening tool for autism in toddlers. Our psychologist is observing, providing some feedback on that, conducting a clinical interview. And then at the conclusion, we'll either diagnose autism if that's appropriate, rule it out if that is appropriate, or in a small percentage of cases, we'll refer for additional testing. And we can generally do that in-house, sometimes even still accomplish that closer to home for families. Okay, so before I move on, one more thing about that is that what we love the most about this model in particular, and it builds upon the model that we're able to provide even when we have families that are seen for our more traditional diagnostic evaluation, is that our consultants that help facilitate that assessment are the same consultants that are going to be working with the family for that intervention service the very next week or two. So they're there, they're hearing the conversation, they're hearing what the psychologist has to say. And so then when they meet the family in their home or through video conferencing still in the next week or two, they're able to speak to some of the questions that may have come up for the families and able to support some of the next steps. Okay, so now let's shift gears to really focus on the early intervention piece. Whether we provide services in person or via telemedicine, there are three major components of our service model that we found to be important to its effectiveness. The first being the caregiver training piece, obviously. That is at the core of our model and the most important component to supporting these families. The provider support has been really important to us as well, for not only continuing to support families once our services are done, but also just to help make sure that, service providers are all on the same page. Many of our families have a variety of service providers working with them. If we can communicate well and be on the same page about next steps for families, the family's needs, that's been really helpful and made the progress for the family more productive. And then our curriculum modules have really facilitated not only our ability to get a lot accomplished for families in a short amount of time, but also help to give them next steps that they can work through on their own. So for a family to engage in these services, like I mentioned, they must first participate in an evaluation for autism. And that might be through our traditional model or through our telediagnostic consultation. Following that consultation, a triad consultant, a BCBA, an SLP, an educator will connect with the caregiver and the early intervention provider and just get a better understanding of what's going on, what are the big needs for the family, what is the service provider seeing in the child's progress or lack of progress over the last several months. And together they'll determine which curriculum module they want to focus on over the course of the upcoming intervention sessions. Families receive 6 follow-up visits, so it's not a lot, which is why we really want to focus in on what we want to try to accomplish for the family, what their priorities will be for that time. And those visits will happen in their home, sometimes in one of our clinics, or through telemedicine, and to the extent possible in collaboration with that early intervention provider. And then once our services are done, we continue to partner with that early intervention provider to provide some ongoing consultation and coaching as needed. So as you can see, prior to COVID, we were already using telemedicine for both diagnostic and intervention sessions. And we were already beginning to think about issues around overcoming technology barriers, how to effectively coach remotely, and how to train others to use telemedicine effectively. So as a result, our own shift to making everything 100% telemedicine was still fairly heavy, but not nearly as challenging as it could have been. We just had to shift our casual conversations about how to do these things into more formal conversations and start to really think about how to create some of these tools and how to do this really well. So I'm going to cluster what we've learned about successful delivery of telemedicine for early intervention into 3 categories. And the theme is really around preparation. Not maybe it's something that a lot of people want to hear when we're already very busy and strapped for time, but pretty critical when we're thinking about effective delivery of early intervention systems, and something I think that people get more fluent with over time. So those will be clustered into caregiver preparation, provider preparation, and then remote coaching adaptations. So like I said, while it takes a little more time on the front end, we have found that taking the time to prepare the caregiver for all aspects of telemedicine helps that session be more productive and effective. So obviously ensuring the family can access a device that is compatible with video conferencing software is critical. We've gone a step further and even provided a tip sheet on step-by-step instructions on how to log into the software, how to access equipment if they don't have access to the equipment. And for families that are particularly nervous or uncomfortable, and we have a lot of them, we might even do a practice session focused solely on how to join the meeting and talk through what it might look like when we actually do our session. Other things that are really helpful to prep families for are around the space and the materials and the replacement of the camera. So we talk to caregivers about identifying a space that has limited distractions, can help contain the child during the appointment, and has a good Wi-Fi signal. And I think this is a tip that we found helpful across all of our telemedicine appointments, whether it be for assessment or for intervention. We also discuss materials to have on hand that will not only facilitate practice with intervention strategies, because that's important. We want to make sure we have things there that are going to help us practice the things that the caregiver is trying to learn, but also things that might help occupy the child if there's time when the caregiver just needs to talk for a bit with our consultant to really understand what's going on, or if they have a lot of questions. And, one of the things that is so critical to early intervention is being able to observe the caregiver and the child in routine interactions and activities. And so we don't want to lose that just because we're not in the same room with the caregiver. And so the other thing that we spend some time on is how do we place the camera, the laptop, the iPad in a place where we can really fully see what's going on, and then coaching caregivers to just take that with them if they need to shift throughout the house. The other thing that our consultants put a lot of effort into because of some of those barriers we anticipate with telemedicine is lesson planning, connecting with families in advance of the appointment to make sure they have a clear understanding of what the family really wants to accomplish during that session, and we have some mutual agreement. Thinking through how am I going to make sure that I address X, Y, and Z topics and am able to observe the number of routines, the activities that I need to fully understand what's going on with the child and caregiver, and if the caregiver is understanding the strategies. And then there may also be supporting materials that our providers want to share with the caregivers in advance, and I'll share those here in just a moment. So preparing caregivers to utilize the technology, drafting a plan for the session itself, those are fairly straightforward strategies. What can be a little trickier for providers is learning to coach caregivers virtually. So many of us are taught how to assess and work with children directly. Our graduate and certification programs don't often spend much time on how to teach and coach adults. And so even though, even when we are providing services in person, there can be a steep learning curve to accomplish this. And I think that goes to a whole new level when we're trying to do that successfully through telemedicine. So what we've done is spend a good bit of time thinking about what we know about evidence-based coaching models for in-person coaching and applying those to a telemedicine coaching model, because the same components are still important. We want to make sure there's opportunity for observation, there's opportunity for information sharing, there's opportunity for reflection and feedback. And even the hardest thing potentially through telemedicine is there's opportunity for modeling. And that's one that we have to be a little bit more creative about when we're not in the same room to put our hands on the child and show the caregiver exactly what we're describing. So we've taken some of that information from the other models that we've adopted for in-person coaching, from what we believe to be important for telemedicine coaching, and put that into a checklist for ourselves to hold ourselves accountable that we're continuing to incorporate things that we believe are important for intervention, and also to share with other providers who are just embarking on this for the first time. Another resource that has helped us overcome challenges related to remote coaching is the library of online courses and videos we've developed over the past several years. So all of the curriculum modules I described before around communication, behavior, social play, toileting, sleep, we've converted into brief online courses that caregivers can access at their own pace. And those courses include video examples that help with the modeling piece that I mentioned, interactive activities, and tip sheets and goal planning, and all sorts of resources to help families take some of this general information and apply it to their own situation and their own child. And these are free to families and to caregivers. And if it's something that you're interested in, you can access them at vkclearning.org. There's a quick registration. You won't get bombarded with spam or junk mail. Just lets us know who's kind of accessing those and where the needs are. Finally, I won't spend a ton of time on this. I know this is something that the Mailman Center focuses on a lot, but our model wouldn't be as successful as it is without the partnership we've established with Part C. So throughout COVID, and as prior to COVID and throughout COVID, we've continued to really focus on how to connect with other service providers. We have built virtual professional learning communities where providers can come together on a monthly basis, hear from us, but also share case studies with one another and troubleshoot and problem solve together. We continue to co-treat, and that has actually been an easier thing to do while we've been using everything through telemedicine. When our providers aren't spending a lot of time on the road, their schedules are a little more flexible and they're able to join us a little more frequently. And we've spent a lot of time providing some of this information about how to coach caregivers remotely, how to support caregivers from a distance with these service providers as well. So our co-treatment sessions have kind of doubled as an opportunity to share information about autism and early intervention strategies and behavior, but also how to effectively coach caregivers in person or through telemedicine. I want to shift now a little bit from describing our services to how we collect data on that model and what that data is telling us at this point in time. Fortunately for us, we had shifted about a year or so ago from the paper and pen version of data collection to a web-based application for that. And so we do collect a decent amount of survey data from our caregivers, our providers, and even our own consultants prior to our intervention services with families, and then again at the end. And through RedCap, we're able to send families a survey link by text or email where they can directly input that data. We've really struggled over the years to get the right measures in place. Our services are brief, so we don't expect huge changes in child behavior over the course of 6 weeks, but we do hope that caregivers will gain confidence in their own ability to support their child's development and that they'll perceive some impact on their child's skills and behavior over the course of treatment. So the measures we collect do include a number of self-report and a couple of standardized measures to just assess that perceived impact of our service on the caregiver, the child, and other service providers. I'm not going to go through results across all of this because it's early and I don't want to put anyone to sleep, but I did want to share some interesting findings that we have come across just recently, kind of as a result of the pandemic. So for us, this might be the small silver lining that has come from this, is that by the end of July, we really had 3 distinct groups that we could look at and think about how the outcomes of our services might vary across these groups. So we had a group that received our services entirely in person prior to COVID. We had a group that received some hybrid of services, either because of where they live geographically or because they began services with us in February and their services carried over into April or May. And then a cohort of families who received our services entirely through telemedicine. So we have taken a really deep dive into that data and have a paper in review taking a look at the outcomes there. Hopefully you'll see that in press pretty soon, but I do want to share a little bit of it with you today. So we're really interested in how much our caregivers learn over the course of our intervention sessions. As I mentioned, we have the curriculum modules, and each curriculum module has a fidelity checklist for caregivers. What are the skills that we really hope that they're able to understand and also apply at the completion of our intervention services? What we see, our consultants actually complete this on the caregiver, and what we see is that caregivers are able to really demonstrate a lot of the information or a lot of the skills that we want them to while we're delivering treatment. So our consultants will fill out this checklist at the end of each session to say, these are the items I was able to cover. These are the items I was not able to cover, either because they didn't apply or we ran out of time. They'll also check what the caregiver was able to demonstrate. So what did they achieve within the course of that session? And then at the end of our services, they'll take a look at what caregivers maintained. And generally, we're seeing good rates of both achievement and maintenance at the end of our intervention. What's most significant for this conversation is that our average treatment fidelity did not differ between, not significantly anyway, between our treatment groups. And so that's really encouraging to us to suggest that we can do this as effectively through telemedicine as we're able to in person. One of the other things we're most interested in is how our services impact caregiver comfort and confidence in addressing the needs of their child. To that end, we ask families to complete a quality of life survey that we developed here in-house. And on that survey, caregivers rate their own confidence as it relates to knowledge of child development, their child's special needs, how to access resources and services, and how to address their child's needs at home, during daily routines and errands, and on bigger community outings. Across groups and items, we see modest to significant gains from pre to post intervention. Between groups, we saw more significant gains across a larger number of items. For our telemedicine group, the growth seemed to really be focused in on child's special needs. And then for our hybrid group, interestingly, the greatest results were in our caregiver confidence around routine errands and community outings. To be honest, I don't know what to say about that, but I do think that it warrants a little more investigation on our part to really get at what are the differences in how we're delivering the services or what kind of information we're delivering that might suggest some of the differences here. We're also interested in both caregiver and triad consultant perception of improvement. So we ask our caregivers and our consultants to complete a clinician global rating scale of improvement post-intervention. And they're rating improvement on things like the child's participation in caregiving routines, play-based routines, the child's verbal communication skills, nonverbal communication skills. 1 on the scale means very much improved. A 7 means things got worse. Anything under a 4 means that things got better. And so we are consistently seeing that caregivers and consultants are reporting improvement. And we're also really encouraged that our caregivers and consultants are in pretty good agreement about how much improvement they're seeing. We did, across groups for this measure, see slightly more improvement reported by our in-person group. As I mentioned, we haven't used a lot of standardized measures, but 2 that tend to get directly at some of the things that we think we impact over the course of treatment are the Communication and Symbolic Behavior Scale, the CSBS, and the MacArthur Communication Development Inventory. On these 2 measures, we see some pretty significant growth, and we're really encouraged by that. So we ask caregivers to complete the caregiver interview portion of the CSBS at pre and post intervention, and we see significant growth across social, speech, and symbolic communication domains for our caregivers. And we also ask them to complete the short form of the MCDI to measure the child's receptive and expressive language skills, and we see significant growth there too. What's most exciting to us for this particular topic is that there were no significant differences between groups on the CSBS or our MCDI. Caregiver satisfaction is obviously very important to us, so we use a 14-item questionnaire that includes items related to satisfaction with the service model itself, satisfaction with our consultant, and the caregiver's perception of impact on themselves and their child. Across the board, we see high levels of satisfaction independent of the group that the provider or that the child or the caregiver is participating in. And these are some of our highest rated items. The consultant understood and addressed our needs. The consultant provided useful recommendations. And most importantly, I was pleased with the outcome of the services for me and my child. We asked the service providers that we partner with to complete the same questionnaire, and we want to get their input on whether or not they found the service to be a good fit for the family, that there were good outcomes for the family, that they were satisfied with their partnership with us. And again, we get high ratings across the board. We did for this group actually see higher ratings in the telemedicine only group versus the hybrid group and the in-person group. And at this point, we're hypothesizing that might have something to do with the ease of the access for our service providers to access our service via telemedicine. To collaborate for an in-person visit means potentially an extra home visit. It means tackling some scheduling barriers when those providers are having to travel, as I mentioned earlier. And the telemedicine really gave them more opportunities to co-treat and attend sessions with us. I also wonder, our team wonders, if this happens to have anything to do with us being able to be responsive to these providers during a time when they were embarking on a fairly new journey of providing services via telemedicine. So for many of our early intervention providers, like other service providers, telemedicine was a new journey, a new thing. And so we were able to be with them for that journey and help get them started. And so we're a little bit suspect that might have something to do with it as well. We did send a separate survey to our caregivers regarding satisfaction specifically with the telemedicine service itself. We wanted to know, did you feel like your provider was able to engage well with you? Did you feel like the lines of communication were as effective? And did you feel like your privacy was respected? And across the board, we got strong ratings on that as well, with some additional comments about the conveniency of the telemedicine and the opportunity to continue services despite the pandemic. Some of the last data that I will share with you, if you're still hanging on with me, is the satisfaction with telemedicine related to the perceptions of our own service providers, so our Triad consultants. We wanted to know, what was your experience with that? So we asked them to complete this survey, really thinking about, do you think this is an acceptable way to deliver services? Do you think this is a feasible service for families? And what's your comfort level with that? Again, our providers felt like telemedicine was feasible and acceptable, a good method for delivering early intervention services. And they also felt comfortable delivering services, doing many of the same things, establishing rapport with families, conducting observations, monitoring progress via telemedicine versus traditional. So there are obviously a lot of benefits to telemedicine. I'll share here just a few that we want to highlight and that we've seen in our own program. So we know that many families struggle to access services due to travel and transportation barriers or difficulty scheduling sessions on top of already busy schedules. So for many, telemedicine offers an opportunity to reduce or eliminate those barriers. Our consultants also reported an increase in family engagement during telemedicine visits. When the expert isn't in the room to take control and manage the interaction, our caregivers tend to take a more active role in treatment protocols. And that's great because we're not going to be there forever. Our consultants also reported logistical benefits related to telemedicine. Many of our own and other providers travel that 1 to 2 hours or more to work with a family. Telemedicine allows providers to still see families in their natural environment, in their home, which is critical, but without time lost to travel. And so for our consultants, this meant more time to plan for each session and a greater number of families that could be seen each week. And then lastly, the ease of inviting another provider to an intervention session simply by sharing a Zoom link made it easier for our consultants to collaborate with providers external or internal to our organization. Regarding challenges, not surprisingly, many of our consultants reported experiencing technology-related challenges, including unreliable internet and difficulty setting up cameras. Establishing caregiver buy-in. So we saw a decent amount of this at the beginning of COVID, with many families saying, oh, it's fine, we'll just wait and resume services when this is all over. It only took a few weeks for our caregivers to reach back out and say, okay, it doesn't look like this is going to end quickly. Let's go ahead. And generally within a session or two, our caregivers were feeling much more comfortable and bought into the model. The inability to model strategies with the child, which I've already touched on. And then addressing severe or aggressive behavior can be a little trickier when you want to make sure you're keeping the child and the caregiver safe, and we're not there to directly intervene. So just some things that warrant further thought on our part. So what's next for us at Triad? We'd really like to give further thought to how to address some of these technology barriers, how to identify additional communities within which to replicate these services, and to continue to really define what it means to deliver quality early intervention services via telemedicine. We really want to focus our future efforts around this technology barrier and can we build technology libraries where families can check out equipment so that they can access a specialty service provider even for a short-term basis? Or can we set up more of these satellite clinics where families can go closer to their home but still connect with the expert that they need to address the needs of their child? We want to think about how we can identify additional communities and their relevant needs. What we learned from our first venture into the western side of our state with the telediagnostic work was that there were a lot of families that were not being referred for services because providers knew that they couldn't access them, they couldn't travel, they couldn't get off work to make the appointments. And we feel like there's a lot of other communities out there that are dealing with a lot of the same things. And so we want to identify those communities and really partner together to think about what the specific needs are within those communities, understand those, and then work to build more sustainable models like the ones that I've talked about here today across these other communities. The eastern side of our state is highlighted here. I haven't talked about this in great detail, but our service model is provided pretty much throughout Middle and West Tennessee. We see around 150 to 200 families a year through those two regions. And just as of March of this year, we've started to pilot some of this work in East Tennessee. So that's one of those areas where we're really trying to get to know the communities and what their needs are. And lastly, we want to think about what the facilitators and barriers are to the successful implementation of telemedicine services. So not only how do we as providers do this well and how do we monitor quality of services when it's delivered via telemedicine, but also what's working for families and what's not. We did lose a few families over the course of the last several months. And, you know, it could be that that had absolutely nothing to do with telemedicine, but it could be that it just wasn't the right fit for them for whatever reason. And so continuing to understand goodness of fit for families and how to make it a better fit over time. I want to give a special thanks to our partners at the Tennessee Early Intervention System, our TRIAD directors, our early intervention coordinators and consultants, and most especially the families that have welcomed us into their homes. Here is some contact information for myself and a Twitter and Facebook handle if you would like to stay in touch with what's going on at TRIAD, as well as our website. And there I will open it up to questions.
Great. Thank you so much, Dr. Stainbrook. So please, if you have questions, you can put them in the chat box or you can open yourself up and talk. One of the quick ones right away from Dr. Hernandez is, how do you know when caregivers and providers are ready?
That's a great question. So I might need a little clarification. Ready for intervention in general or ready for telemedicine?
Julieta?
Both. But it was the emphasis on for the intervention, because I come to realize that preparation is key for the success of the intervention.
Mm-hmm. Yeah. So I think, gosh, I would say all of our families probably, we want to provide the intervention to all of our families, right? And I think all of them, for the most part, are ready, maybe at varying degrees. And that's where I think we play a role in getting to know that family and what is important to them and what is valued by them and meeting them there. And so we might have a family that feels like, yeah, I don't really have any concerns. I don't think we really need any help. We might dig a little deeper and discover that there are some routines or times of day that are particularly hard. And even though we might want to focus on something else that is glaring need for the child, we'll go to that space with the caregiver just to get some of that buy-in and get them kind of more ready for early intervention services. But I do think, to generally answer your question, caregivers need to see a need. They need to see a need and they need to want change. And that is going to make our jobs a lot easier.
We might shift to the policy questions for a couple of minutes and pick up on some of the things in the chat. And the first quick question is there any cost to families? Are these considered Part C services, or do you bill Medicaid and insurance? How does it work out?
Great question. So right now there is no cost to families. That's where our partnership with Part C has really helped. So they fund all of this as part of the child's IFSP, part of their standard early intervention service. That's for the intervention piece. For the telediagnostic work, we are billing insurance.
And so just to put this in context for everyone, I'm sure Medicaid is a lot like Florida. So Florida's total budget for our state is $90 billion with a B. And Medicaid is $30 billion. So 1/3 of every state tax dollar goes to Medicaid. And one of the biggest costs in Medicaid recently has been ABA. And if you remember, Dr. started by talking about how there are all these requests for ABA for children with autism, which costs around $35,000 a year. So I wondered, just Dr. Stainbrook, do you have a sense of how much your services cost compared to that? Because this may be something that Florida is very interested in picking up on as well.
Mm-hmm. So we have done that cost analysis, and I can tell you it's positive. I don't have the numbers tucked away in my head, but that is exactly why Part C wanted to embark on this collaboration, because they had a lot of families coming through their doors asking for intensive ABA services. And for many of these families, that will still be the trajectory, and that will still be our recommendation. For some, we're able to meet their needs with continued early intervention services and community-based programs. And so our services do end up being more cost effective than Part C paying for 25 hours a week of ABA. Many of our families, like I said, will still end up there, and that's where we'll want them to be. But generally that was the focus of Part C and continuing to partner with us, was how can we meet the needs of our families with the limited funding that we have.
Other questions from the audience? I have lots more questions, but I'm trying to be polite to others. So following up on that last question,
Sure.
Are you able to, if you do decide the child has a more complex needs and ABA is appropriate, do you still do the same kinds of things, or do you sort of say, okay, we're not going to do the coaching model because this child's getting a different set of treatments?
So we do go ahead and provide our services. That helps us get to know the family a little bit more. It empowers our service model is really focused on empowering the caregiver to get things started at home. And so we still want to provide that support. And there often are questions around the evaluation and the diagnosis that we can help with. Also, if our families, even if a intensive ABA program is the route that we're going, it's going to take a minute to get that set up, and we don't want to leave them just waiting. And so we like to sometimes think of our service as a jump start or something they can do while they're waiting to get off of that wait list for whatever program that might be. We also like to, when possible, have a warm handoff. And so we've been able to get to know the caregiver and the child over those 6 to 8 weeks, and then we're able to help hand them off to that other provider for more intensive services and get them going a little quicker.
Great. We have time for 1 or 2 more questions, and I see in the chat box that Angela Garcia is asking, what type of ongoing training do you do for your consultants?
Mm-hmm. Great question. So for our in-house consultants, we do a lot within our team. So we have weekly team meetings and case study shares, and are trying to learn from each other on a regular basis. Right now, we frequently will seek professional development from external entities. So right now we have several of our providers going through coaching with Julianne Woods from FSU, actually, for FGRBI. And we send them to conferences and to behavior analyst events to the extent that we can. For our other providers that we work with, we are continuing to provide training through webinars, through these professional learning communities, through models that look a lot like ECHO but aren't quite ECHO, and then continuing to co-treat and coach those providers directly in sessions.
And a question from Raul Paulson, one of our child psychiatry colleagues, says, great presentation, very needed service for remote and limited regions of our state. Thank you. And the question is, what are the factors that limit the service to 6 to 8 weeks? Is it the scope of the service? Is it the funding that you have? Is it the amount of families that are available for services? What's the limitation there?
Yeah, all of it. So, we have been through variations of this. There was a time when we provided 2 visits. There was a time when we provided 12 visits. 6 to 8 has been our magic number. We don't have a lot of science behind that, mostly just experience. what we initially based our number off of was how many sessions do we feel like we need to get to know a family, get to know the need, share some information and see an impact, and make sure we don't have families on a wait list. And so right now we're able to see families, all the families that come through our doors through the early intervention system without a wait list. We're getting really close to that not being possible anymore. And so we'll either have to grow our team or adjust our model again. But it's a combination of those factors really, and how much support do we have from the state to hire consultants, how many kids are coming through our doors on a weekly or monthly basis, and then how many weeks does it take to actually be able to build a relationship with a provider, share some information, and see some gain.
So great. We're, as I told you at the outset, trying to get to stopping it at the hour so we can all get to our various next steps. It's been wonderful. Just to sum up a couple key things for our audience, the data on the equivalency of telehealth is really wonderful, since we've all been deep into this as you have, and it's nice to know there's some evidence to suggest that this actually works as well as our in-person stuff. And for folks to know, our Part C programs in Florida is really moving towards a coaching model as well for children with developmental delays in general. We haven't done this as much with autism, and I think this is a great model. So it's very likely that our Part C partners will be reaching out to you, Alacia, so that we can see if there are some things we can do here in Florida as well. So I will now ask everyone to please, in a virtual applause, join me in thanking you for coming down today to Miami and getting up an hour early. And it was really wonderful. Thank you very much.
Thank you. It's lovely to be with you guys.
Have a great day, everyone. Bye-bye.